So good morning, everyone. My name is Audrey Paddocks, and I'm the research manager at the McMaster Institute for Research on Aging. Thank you for joining us today. Today's seminar, Supporting Older Women in Ways That Work, is part of the Mira One Topic, Two Disciplines series, where we bring together experts from two very different fields to discuss important and complex topics in aging research. This series aligned with Mira's goal of supporting interdisciplinary collaborations among aging researchers across McMaster. So today's presenters will be using slides, so we suggest you switch your view to presenter view, which is in the upper right-hand corner. Please mute your microphone if you've not already done so. If a question or comment occurs to you during the presentation portion of the seminar, we ask that you type the question or comment in the chat box, and then we'll return to those during the discussion period at the end of the seminar. Please note that this meeting is being recorded. So we will begin today by giving honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands where McMaster stands and where I am right now. To say that is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have with this land, and to reflect on how we each can do more to learn more about the history of this land so that we can be better residents, neighbors, partners, and caretakers. Our speakers today will consider the ways that women's health and aging are experienced and viewed through cultural, social, medical, and public health lenses. First, Dr. Alison Shea, who's an assistant professor in the Department of Obstetrics and Gynecology and an associate member of the Department of Psychiatry and Behavioral Neurosciences at McMaster University, will speak. After becoming a certified menopause practitioner through the North American Menopause Society, Alison completed a fellowship at Mount Sinai Hospital in menopause and reproductive mental health. Her research interests are focused on determinants of health among middle-aged and older women as they move through menopause, as well as the role of reproductive hormones. Alison is interested in both the ethology and treatment for bothersome symptoms affecting the quality of life among midlife women. Then we'll hear from Dr. Saara Greene. She's a professor and director of the School of Social Work at McMaster University. Her research focuses on reproductive and maternal justice and barriers to care for women who experience marginalization across multiple axes of identity and across the lifespan, including women with HIV. She has been leading arts-based participatory research on women and cannabis since 2018, and previous work has looked at the needs and experiences of mothers who consume cannabis during pregnancy and breastfeeding, and older women who use cannabis. She grounds her research in feminist participatory action and arts-based research approaches using body mapping, photo voice, and more recently, cell film. Her strong record of research and publication shed light on important social and legal issues faced by women identified individuals who experience stigma and marginalization along multiple axes of identity. I would like to hand it over to Alison, who will speak first. Alison, if you can share your screen and I will stop, and we'll take the questions at the end of the presentations.
Okay, excellent. You can see my slides now and hear me? Yeah, okay, excellent. Thank you for inviting me. I am very excited to be here today to hopefully open the dialogue about how women move through the menopause and how often they feel about their body, mainly as in their sexual function, as well as their urinary function, and really just comfort of all the reproductive organs down below. There's a lot that's not talked about, and hopefully just open the dialogue and break the silence. Okay. So I'm going to start off just with right into a case. Okay, so Mrs. M is a 52-year-old woman who had her last period about 2 years ago. She's noticed that sex has become increasingly uncomfortable over the last few years, which is very common. One time she noticed light bleeding after. Now she's been avoiding intimacy with her partner because she's worried this will happen again. This has started to affect their relationship. She's now struggling with her self-esteem and her mood as a result. She's not feeling very good about herself. She's not sleeping well and her appetite is reduced. So she makes an appointment with her family doctor to talk about her difficulties falling and staying asleep. So she sees her family doctor, who identifies as male, an older male. She mentions that she's having trouble sleeping. He asks her about things that might affect her sleeping: caffeine, alcohol, screen time, mood, stress at work. But he doesn't ask her about her relationship with her partner. He doesn't ask her about her sexual function. He doesn't ask about menopausal symptoms. He doesn't ask about whether she's experiencing hot flashes, which is common, whether she's experiencing night sweats, which may be affecting her sleep. He doesn't ask about symptoms of vaginal dryness or pain with sex. At the end, he gives her a prescription for sleeping medication. So menopause is a normal physiological event following the final menstrual period and reflects a loss of ovarian follicular function. So the ovaries run out of eggs. There's no more eggs to come out. And you have, as a result, low estrogen levels. And this affects basically everything in your body. Many symptoms that affect the quality of life. The mean age is 51 in Canada, but can occur earlier for many women, can occur earlier because of iatrogenic menopause as well. So treatment for cancers, breast cancer, many of these symptoms are quite prevalent at an earlier age for those who are cancer survivors. And the menopause transition is when the periods start to change, you start to get hot flashes, some of the symptoms start to occur. And the menopause transition can take anywhere from 4 to 8 years. And the changes in your body start to happen around this time. So women can start to be experiencing these symptoms in their even early to mid 40s. But the definition of menopause is 1 year of no periods in those with an intact uterus. So I'm going to focus mostly on the terminology genitourinary syndrome of menopause, which is a newer term. We used to refer to this as vulvovaginal atrophy, but this is an all-encompassing term, which includes burning down below, itching, pain with sex, pain with voiding, dryness, and this is due to a decline in estrogen levels. We know that this leads to decreased blood flow, and that leads to less moisture. When you have less blood flow, you don't innervate the nerves as well, so things don't feel as well. You have decreased lactobacillus, and this results in a more alkaline pH, which makes you more susceptible for urinary tract infections. Women often get recurrent urinary tract infection or other infections such as bacterial vaginosis. Can be associated with bleeding following sex. Bleeding after menopause, the most common cause is actually the walls getting thin and the dryness rather than something more serious. So this is the most common cause of bleeding after menopause. This tends to worsen over time. Women also report urinary symptoms, so having to go more often, urgency, they're up at night more often. As I said, recurrent urinary tract infections, and this is related to a change in pH. So this is just a schematic diagram looking at the changes in the vaginal mucosa. So that's basically the skin inside the vagina. The skin inside the vagina is basically like the skin inside your eye or inside your mouth. So it's very sensitive. Before menopause, you have this moist and thick epithelium. So that skin of the vagina is very thick. It's very moist. There are a lot of layers. But then after menopause, it becomes much thinner. There's decrease in the superficial cells, and there's a lack of renewal of the epithelial cells. So it becomes thinner, it becomes more like tissue paper. It's more friable, more able to tear, getting microperforations and causing bleeding. So the question is, are women talking about this? How do women feel about this symptom? So the main symptom of vaginal atrophy. So this was a study that was a structured questionnaire of over 4,000 women from several countries, Canada, US, Finland, Sweden. And they found that 71% of women who experienced these symptoms down below, these vulvovaginal symptoms, had not discussed it with their healthcare provider. So women aren't coming forward. And we see this in many studies. And 30% of these women indicated they preferred for their healthcare provider to initiate the discussion, but I don't think a lot of healthcare providers are necessarily doing this. 42% of women didn't know that there are local non-systemic treatments that existed that are very, very helpful. This was a bit higher in Canada. About half of women didn't know that there were good treatments available, and most hadn't received treatments for their symptoms. So when they asked women, why do you not talk about this? And these were the answers. So, large majority, they said they didn't think people wanted to hear about their vaginal problems, even though they were quite uncomfortable and having symptoms that were affecting affecting their quality of life, made them feel uncomfortable or embarrassed, very common, or it's private, doesn't concern others. So women were suffering in silence. They weren't talking about it. Healthcare practitioners were not asking. They weren't bringing forward the information. Many women just accept this as part of growing older, not knowing that there are good treatment options. And just as I said, a lot of people didn't feel comfortable talking about it. So it's important for healthcare providers to ask the right questions. So Mrs. M continued. So she has been taking her prescribed sleeping medication. So it's been helping a little bit, but she's still feeling down about being less intimate with her partner. She tries intercourse again, and then she has bleeding. So then she books another appointment with her family doctor. She's also noticed that it's very itchy. So this time her family doctor asks her some questions about the bleeding, wants to rule out cancer. So he orders a pelvic ultrasound. He does not examine her or ask about pain or with sex or itch. And he doesn't offer any counseling around intercourse after menopause. He's more concerned postmenopausal bleeding. You know, when we hear postmenopausal bleeding, we always want to rule out uterine cancer or any other reproductive cancer. So he wants to rule that out, but doesn't ask about anything else. Even though, you know, I mentioned the most common cause for postmenopausal bleeding is the vulvovaginal atrophy and the dryness, the thin tissues. So she takes matters into her own hands. She goes to the drugstore and she's very itchy. So she goes to the women's area. She finds something called Vagisil, maximum strength anti-itch cream. Okay. This is the worst thing that you can do. You want to avoid all irritants. So Vagisil itself has 4 different ingredients that are irritants. So one is diamdienhydantoin, which is a formaldehyde. It has parabens in it. Anything that has parabens in it is irritating to the epithelium. There's also red dye in some of these, and they also have benzocaine in them. So it takes the itch away because it's a local anesthetic, but then it can cause a contact dermatitis and make things worse. So really, for women, particularly as they move through the menopause, you want to avoid kind of anything. You don't put anything down below if it's irritated. So no Vagisil, no fragrances. Avoid maxi pads if possible, especially Always brand because they can be irritating, and cotton underwear only. But again, these are all things that her family doctor didn't really discuss with her or ask about. So what can women do to help themselves? So just from the straight off from the get-go, most women will need a lubricant after menopause. Even majority of women, even in their 40s, will find that the lubrication is not as prevalent as it was before. So there are very good lubricants out there, but there's a lot of really bad lubricants out there. So a lot of them have preservatives in them, which is not great. So you want to think about the pH and the osmolality, so the water content. So the vaginal pH is ideally more acidic. And so is acidic about 3.8 to 4.5. So it's important to consider the pH. In terms of the osmolality for products, the WHO recommends an osmolality of about 380 to minimize risk of epithelial damage. I'm going to show you a table on the next slide about what the various lubricants and moisturizers are and how they might be making things worse. So a good lubricant that I recommend is Good Clean Love. You can get this at most shoppers now. It has a good pH and osmolality and has no preservatives in it. Very, very good option. In terms of moisturizers, so just like moisturizers for your body, there's different moisturizers for your vagina. So these, you can use coconut oil. It's non-irritating, and you can also use that as a lubricant. There's also hyaluronic acid-based moisturizers. So one of them there is Repagini. This is all over-the-counter products, and you can get them in the women's section or behind the counter. So for women, you know, what's in your lubricant or moisturizer? So many women are using Replens here. Okay, Replens, this is your pH and your osmolality. The osmolality is over 2,000. The WHO recommends no higher than 380, but they'll allow up to 700. So the Replens might feel good initially, but then it's actually causing denudation of the epithelial layer and making things worse. But women don't know that. Things aren't talked about. There's not good education for women, and women go and Google stuff. They talk to their friends and they wind up using these products that actually can make things much, much, much worse. So really, you know, putting Replens on your vagina is really like putting a lemon on there and sucking everything out, and it's too acidic as well. You know, down here, KY lubricant at the bottom, again, look at the osmolality 2007, you know, that's way higher than the recommended 380. So, you know, basically most things that you're using, throw out. What we recommend here, good, clean, love lubricant is good. Yes, vaginal moisturizer, also good. So what are the good therapies that are available, prescription therapies for GSM? So there's local vaginal estrogen products. There are many of them. This is low dose therapy. It is not systemic, does not increase your risk for anything that's scary in terms of hormones, does not increase your risk for blood clot, stroke, breast cancer, cardiovascular disease. There are creams, there are tablets. And now coming October 11th, we are also going to have a really great product I'm really excited about called Intra Rosa. So this is a DHEA suppository. It's listed there in the bottom. It's going to be it's been available in the US for several years. So this is a suppository. It's DHEA. It breaks down into estrogen and androgens. It's a suppository you use every day. It can be used for breast cancer survivors. And helps to improve the dryness. It's actually shown to improve female sexual function index as well, to improve, to have modest increases in sexual desire as well. But if women are having pain, you also want to, be interdisciplinary and think about other causes of sexual discomfort. Many women have pain with sex, or they may have because of the muscles, or they may be having incontinence, and that may make them feel less desirable. It might be uncomfortable for them. So certainly, getting the help of a pelvic floor physiotherapist can help most women. Most women would benefit from seeing one, and they can self-refer. There's many of those in the area. And women can find one that's near their house by going to pelvichealthsolutions.org. Moving on to sexual dysfunction. So again, many women, just think this is a natural part of aging, and this does not have to be. It's very common in mature women. Low desire is common as anywhere from 50 to 70% after menopause. Starts declining about 18 months before the final menstrual period. Hypoactive sexual desire disorder, or HSDD, is when you have low desire and you're bothered by it. So it's considered a disorder, and this seems to be higher in surgically menopausal women. We do know that when you still have your ovaries in situ, you still get little bits of testosterone from them. When you get the ovaries removed, that is taken away. But sexual dysfunction in mature women, it's multifactorial. Certainly vaginal dryness and pain with sex, which is dyspareunia, are involved. Stress, depression certainly can kill your sex drive. Many women are suffering from joint pain or other medical comorbidities. Obviously, that can make sexual intercourse more challenging, and women may want to avoid it. Maybe problems with the partner, maybe the partner's not that engaging. Women will come to the office and say, well, I don't really feel like having sex. And, say, well, do you go for dates? Do you spend time with each other? They said, well, no, my husband or my partner just wants to watch the sports all night and then gets into the bed, and then we haven't really hung out, and then wants to initiate. And it's just like, we haven't really engaged with each other. So it's hard for many women to feel engaged and want to feel in the mood. So really working on the relationship and working, making sure that they are connecting both intellectually, romantically, and then that will hopefully lead to an increase in sex drive. There are other medications that also affect sex drive. So I just briefly mentioned hypoactive sexual desire disorder. So this is a loss of sexual desire causing distress greater than 6 months, not due to medications or other conditions. And there are a number of screening questions asking about if this is bothering them, if they previously had sexual desire, and if they want them to increase. So what are the options for sexual dysfunction? So certainly treat the vaginal symptoms, talk about lubricants, decrease the stigma, tell women that, most women need a lubricant. This is normal, and you can really improve it. Just have it at the bedside, just have it ready. Don't judge it, and just have it there. And you can use it in foreplay. It can be a nice add to foreplay. Optimize their relationship. As I said, often partners aren't going to bed at the same time, so they're not opportunities. They're not, they're sitting on separate couches while they're watching their show, and then they're not really having any physical intimacy at all. So, start with the basics, go back to basics, and sitting on the same couch, starting with holding hands, and then slowly build that up. Many people will benefit from couples or sexual therapy, just to open the dialogue, if the partner is willing to talk about it. they're not always open and open for this. There's a good book by Dr. Laurie Brotto. So this is a sex therapist. She's Canadian. You can get this on Amazon, called Better Sex Through Mindfulness. And then in terms of medications, that we have prescribing guidelines for the off-label use of topical testosterone gel, and this can improve libido for about 50% of women, but you have to monitor the testosterone levels to make sure they don't get too high. Side effects would be acne and unwanted hair growth. There is now Addyi, which is flibanserin, which is a pink pill. This is a pill you take every day, which is approved for premenopausal women, but there is certainly some efficacy for postmenopausal women to strengthen sexual desire. The bottom line, though, is that women don't have to suffer in silence. So really just to talk about it, break the silence, speak openly, avoid ageism. Women can be sexual beings, as they mature past menopause, but they need to know that a lot of things that they're feeling and experiencing are very common, but, we have good treatment options, and that, it might not be the same as it was in their 20s, but we can at least help them to get them a little bit better, and get them to reconnect, and that we have a lot of good treatment options, and just advocate for your patients and normalize and patients to advocate for themselves, and talk to their providers, because often providers aren't asking, but just really to providers ask the right questions, because many women are shy or embarrassed, or they think it's a normal part of aging. So that's all for me. I'm going to hand the floor over to Dr. Greene, and I'm happy to welcome questions at the end.
That was great, Alison. So I guess I'm just going to go right into it. And okay. So I actually want to start with from what Alison was saying about women taking matters into their own hands, because I really feel like that's a theme here, and it could have actually been the title of our presentations today, because this project around cannabis and aging for women really is very much about women growing older and who are taking matters into their own hands. Sorry, I'm just seeing what's going on here. Okay, it's got some weird thing happening, which I don't know how to change, so bear with me. And I'll just say thank you to Audrey for the lovely acknowledgement that you did earlier, and to also thank the women who participated in this pilot project, and my fantastic research assistants, and as well as the Michael DeGroot Center for Medicinal Cannabis. So I'm going to start with a quote from one of that was connected to one of the photographs that the women in this project shared, which is just fantastic. And she says, what made me feel it was a safe thing to do, and she's talking about cannabis here, is my grandmother, being already very old, telling me the story of when she came to Canada. She had rheumatism and she was prescribed a tincture of, I don't know what it was called back then, but it was essentially cannabis. And that she used it for a long time, and it really helped her a lot. And then she could get it in the pharmacy at the closest city where she lived, and she always challenged authority. And so this particular woman was talking about how she always questioned that, because in the 60s, everybody was trying it and questioning it. So why is it suddenly illegal when it helped people? And here we're talking about women's experiences of attempting to access and consume and use cannabis in their everyday lives as something different to what would normally be prescribed to them through pharmaceutical drugs to help them with various aspects of their physical and mental health. And we wanted to talk about cannabis specifically because we've been hearing from older women that they feel like there's still a stigma for them around expressing their experiences and needs and desires to use cannabis as an alternative approach to dealing with mental health and well-being, and to be able to speak to other women about it as well. So we grounded our project in a feminist approach to arts-based research, and where we could bring together a diverse group of older women from across Canada to learn about their experiences of cannabis use, their access to medicinal and recreational cannabis, and how they access cannabis-related information and support. And this included women from New Brunswick, British Columbia, Ontario, Alberta, and Saskatchewan. And most of the women were in their late 60s and early 70s, except for one woman who was 52. And I appreciate something that I have learned from my colleague who I know is here today, Dr. Nicole Dahmer, who has really challenged how we define the age range of older women, recognizing that social determinants of health and different experiences of racism and marginalization actually really does impact women's aging experience. Women also had various experiences around thinking about medicinal cannabis, accessing it from legal dispensaries or growing it themselves, or other experiences of accessing cannabis. And they used cannabis to treat a range of health conditions, including physical health concerns such as osteoarthritis and arthritis, as well as mental health concerns like anxiety. So we wanted to use an arts-based approach to engage with women so that we were actually developing questions and ensuring that we were working together as a group of people together to really collect and analyze data that would tell us something about their lived experiences. And because we did this during COVID, we really had to think about how do we switch working together to do arts-based research in person to doing it virtually. The benefits of doing it virtually was that we were able to talk to women from across the country. And for many of them, being a part of this project supported them with their isolation during COVID, knowing that every week for 10 to 12 weeks, they were meeting online for a couple of hours to do artwork and talk about their shared experiences. And so we worked with two different groups of women, two different photo voice groups, where we held weekly workshops where they took photographs that symbolize their experiences related to cannabis consumption and access and information. And we recorded the sessions, we transcribed the sessions, and we engaged the women in analyzing and making sense of their stories and photographs, both individually, but also collectively. So part of what we did is we wanted to really challenge this idea of older women and technology. So we actually did technology training with them on Zoom to teach them how to do photo voice, to use their phone to take photographs, to upload them to a site that nobody could access but themselves, like individually, or the research team. And that was really fun and interesting. And they felt really great about what they were able to achieve through the process. And then we used their photographs that they took on a weekly basis to talk about what those photos meant and what the reflections were, and engaged in collective dialogue. We felt it was really important that we also did education sessions. So at the very beginning of our workshops, we did hold sessions where we could engage them in education around cannabis, both in the legal context, as well as what we knew about the way it interacts with their bodies, and that, you know, that's not a one size fits all sort of thing. And we're able to ask questions, and we had somebody online ready to answer questions that we couldn't answer in real time, which was really helpful. And then we engaged together in both of the workshops with the participants to do a narrative and bit of visual analysis of our data. And today I want to talk about a little bit about the findings, but primarily about how arts-based research is a method in which to really center the lived experiences of women that can be used to mobilize knowledge and experience to stakeholders in ways that are perhaps, you know, speak to people in different ways and elevate voice and needs and desires, in the hopes that policymakers and people working on the ground in social care, in healthcare, can get a better sense of what women are needing, older women are needing. So 4 themes emerged, and that included the high degree that participants rely on their own experiences, research-seeking activities, and knowledge sharing, the importance of accessing peer networks and social media channels for information and support, having access to cannabis, and particularly having control over their mode of consumption. And, you know, for them to talk about the impact that cannabis has had on their capacity to enjoy their life as they age. So there was a real theme around how having control over being able to access cannabis and use it and consume it in ways that work well for them really impacted their quality of life. An important piece for us was also the way that engaging in a virtual arts-based research project during the pandemic positively impacted their lives and their capacity to build relationships and friendships that they wouldn't have otherwise had. And one of the really key things that emerged from this project was that the women developed their own Facebook page where they share information around cannabis recipes, stories, growing, ideas for growing, and just connection. So a little bit about their personal experiences around self-research. This was one photograph that a woman took, and here she's talking about like the work that she does to learn about cannabis, and she drew on this particular publication to help her to learn how to make stuff, with cannabis, like soap and taking a bath, and about how sex and cannabis operates in older women's lives. And this has been, this was something that was then, of course, shared across the 13 women that participated. It became a thing. But really, here is an example of, really doing their own homework to think about how can I use cannabis in ways that contribute to my own self-care. And, it's not about necessarily curing a thing, but making you just feel more comfortable in your own body and feeling good about yourself. And, to the earlier point, Alison's earlier point, even thinking about sex, and like we're older women, we like sex, and how does cannabis support us and contribute to our sex lives and our sexual identities? And I liked how some of them were talking about, you start off small, you get a little bit of information, you learn a bit more, and then you learn a bit more about where you can get more information. And there was just something about the search for knowledge that was an interesting experience for them, because as one woman said, you really have to move past the stigma around consuming cannabis, move past the biases, and to find out what actually works for you and where you can actually go to gather information in ways that doesn't feel stigmatizing. And recognizing that it's actually really challenging because there's a lot of information that's scattered all over the place, and what they're really wanting is one place where they can go to get all of the information that they need. They also talked about the importance of peer support and actually social media as a space in which to access peer support, particularly during the pandemic. But this was really also very important for women who have mobility issues, who live in rural communities, who don't have access to transportation. So this was a way, so garnering peer support through a virtual social media space was really important for them, particularly because of experiences around stigma. And you don't just go out, they would talk, but you wouldn't just bring it up with your friends, because it's not necessarily that all your friends are going to understand, accept, or find this okay. And so one of them took a photo of the She Can website and talked about how this was really important for her to have found out about this website, because it's where people advocate for cannabis and women's needs and desires, and feels confident about the information that she's receiving there, because it is coming from women who have a lot of knowledge, and it crosses sort of identities, professions, lived experiences, and where women can actually ask questions and even engage in more personal chatting. And this is another photograph that one of the women talked about in terms of the virtual spaces that allow for connection and community for women, older women, to talk about their cannabis needs and desires. So the women also talked a lot about wanting to gain a sense of control. They talked about barriers to accessing cannabis and CBD products despite legalization. Part of this was due to differences in provincial legislation, financial barriers, and also around accessing preferred modes of consumption, and also just about, being able to talk about it and find out where you can go and, who you can talk to. Most of the women did not ever talk to a medical professional about their cannabis interests. And so this is a picture that a woman took of her own method of using cannabis to make a particular kind of butter that helps with pain management. And this was amazing because, of course, every woman in the group wanted to learn the recipe and how to make this for themselves. And for her, this was far more, it made her feel a far more sense of control over her health and well-being than going and getting pharmaceutical medications to deal with it. This was what she wanted to have control over, the alternatives, and this is what was working for her specifically. And so we heard stories about the ways in which cannabis improved their quality of life, and that it really helped to decrease physical pain as well as increase mental health and well-being. I don't want to say that this is the way that it would work for everybody in these ways, and different strains have different impacts. And there's a lot of information and knowledge that needs to be garnered around making these kinds of decisions. But again, that's what women were asking for, right? They didn't want to just try a butter or a salve. They wanted to learn more about what it was about that butter or that salve that might be useful for them, and in what ways and in what doses. They also talked about the ways in which cannabis and using it in ways that felt right for them helped them with their relationships. And a lot of them talked about their grandmothering identities and how cannabis supported them with their physical pain to give them what they needed to have to care for their grandchildren. A lot of them were actually like taking care of their grandkids while their own children were at work. And this allowed them to play with them. You know, this woman says, talk about building a snowman and really enjoying this precious time, and, you know, sitting on the floor, playing games, and that this felt like a better option, the cannabis salve, for example, than taking pain opioids or other pain prescriptions, or going for surgery and having parts replaced. Again, this isn't like an instead of, but it was an option that this particular woman felt was important for her to have control over, and it was working for her in this moment. And this is another photograph that this woman took of herself, and we have her permission to show her photograph, that using cannabis to support her with her pain has really shifted her mental health and well-being, not just physically, but now she sees a future that for quite some time when she was living with pain, she couldn't see, and it really did impact her mental health and well-being. And for her, she says that CBD has allowed her to go on a holiday that she didn't think she would ever be able to do again. And she uses oils rather than salves. And this is a woman talking about the positive impact that it has, cannabis has had on her relationship, that it's had an important impact on her physically, emotionally, and spiritually, to be able to do the things that she likes to do and to be able to do those things with her partner. And so this was just a very small project that got the ball rolling and really helped to support an emergence of, like, where does future research really need to be? And it was very clear that a main area was around the ways in which women can access information about and support around cannabis in ways that do not feel stigmatizing or scary or threatening, and really looking towards information technology as one way in which that could be supported. And also, like, the engagement of art as a way to bring something fun and engaging and connecting and community building in women's lives as they do and engage in this research. So I was really lucky to connect with Dr. Nicole Dahmer, who's in the Department of Health, Aging and Society here at McMaster, who does a lot of awesome work around aging and information, accessing information. And we have come together, and we've been funded actually to do a piece of work with some of these women who are going to be part of our advisory board to further develop our research questions and to test out a participatory R-based research approach called cell filming, which uses accessible technology such as cell phones, that's user-centered, community-oriented, and has the potential to virtually support community mobility among women who consume cannabis. And it's also going to help us to think about the potential for creating virtual communities of support using technology for women who consume cannabis, and really thinking about women who have more barriers than others potentially to accessing information and support because of experiences of racism, gender, sexual orientation, space, place where they live, and really thinking about how is it that arts-based research in a virtual context can create supportive spaces for community, as well as accessing information. And there's been some really great research that we're drawing on to help us with this. And in progress, we have a SHRC application that is engaging older women even more specifically around asking the question of how virtual technologies can help to address barriers to accessing cannabis information and support. And I just wanted to end with the last word not being mine. This is one of the women in the Growing Older pilot project who talked about her thoughts and needs around cannabis access. And she talks about the foundation would be the prescription and the cannabis being supplied. The second rock is another, my out services of where I would go for different supports like supplies to get like beeswax, the essential oils, different stores I would have to go to get to make myself. And then the other iron rock in the middle, the flat one, is more like maybe community members who I engage with. Then the top, those two top tiers are the pharmacy or the grower, and then the doctor that prescribes. Once I have the product, then I'd be able to make all these lovely things that keep me functioning and engaged. And how do I stop sharing here?
Thank you very much to both of our speakers. I saw there were a few questions came up in the chat while we were going ahead, and I know that Alison answered one of them sort of directly there. And I think, I mean, to sort of summarize a few of them into one point, I think the question was really around how women might interact with their family doc if they are experiencing some of the things that you described, and especially if they're not getting sort of any resolution to those symptoms and issues, and if you have any advice there.
So yeah, certainly I'm now involved with a patient advocacy group called the Menopause Foundation of Canada. So I urge people to go there. It's an advocacy group nonprofit that was made by two patients who felt that they took them several years to find somebody who listened to their symptoms. So there's a lot of really good information there about symptoms, about the perimenopausal transition, just really accessible information. And in that, well, it's also listed where you can find a menopause provider, and really just trying to educate yourself, and bringing that back to the doctor if you need to. You know, sometimes you say, okay, I've done this reading. This is what I want to talk about. And so you know, you need to have, if you can come, you know, knowledge is power. If you can come with some knowledge and bring that back to the family doctor, or if not, ask for a referral to somebody who might be able to help you with your symptoms.
So I would like to sort of riff on that, because I felt like this was a theme that both of you touched on. And when Saara started to speak, she mentioned this idea of taking things into our own hands as being the place where she would pick up where you left off. And so Alison mentioned a variety of therapies that are effective or not effective. And I wondered if you get the sense that family docs are aware of the data you shared, or if this is a knowledge translation opportunity to get that information to practitioners, because it sounds like a lot of times we're asking people to go and look for that information themselves. And Saara, similarly, you're talking about the ways that this is so valuable to the women that you are working with, is sharing that information amongst themselves. And is this, do you see an opportunity for knowledge translation to sort of medical practitioners and in your work? So maybe you can both take a stab at addressing that question.
Okay, I'll start. So certainly there is a huge knowledge translation piece that I am passionate about and I'm in the process of doing, and the more needs to occur. So, you know, I think family doctors just need to get up to date on their information. Some of them are, some of the younger patients are, you know, we we're doing a prospective database for everybody who comes into our menopause clinic. And we looked at who was referring the patients, and the majority of them were people who were in their first 5 to 10 years of practice. And so I think that the younger generation of new practitioners are aware of the therapies that are available. The majority of the people who referred them were female. So I think more females are asking the questions. Females may be more open to talking to other females. And certainly research has shown that the women spend more time with women practitioners, whether or not they're the same specialty or not. But, recently I've given a talk to the West Lincoln, the family doctors. I'm doing one for the Department of Family Medicine, October 12th on menopause. I'm giving a talk for a drug company, October 18th, which is World Menopause Day. We're generating data from our database that we're doing prospective data collection on. And we have 2 sites, Mount Sinai and McMaster now. And we've just applied for CHR to expand that to more sites to hopefully see what people are getting referred for, what they've tried, if family doctors have tried anything, and then to create tools to bring that back to hopefully create more easy to follow, flow charts, resources that family doctors can refer to. But you certainly just getting the word out. And I think the time is now. I think that women want to be heard more and more. And I think that the silence is starting to be broken. And so I think we're going to see big changes in the next 5 to 10 years. And certainly, yes, we just keep getting the word out there. Yes, there are many more opportunities.
Thanks, Alison. Saara, would you like to address the same question?
Yeah, I can answer it from a different perspective. This is very early days of this research, and just in terms of my approach to doing the research is really working with the women themselves to figure out how they want to mobilize this information. And, they were really grateful that I'm doing this presentation today, but we are actually really talking about with the women themselves, like how they can be a part of that knowledge mobilization process. They were actually less interested in talking to their family doctor than seeing some other more sort of structural changes around their access to cannabis and having control over accessing cannabis and where they can get cannabis and how they can use their cannabis. Because again, even though it's legalized in Canada, since 2018, there's a lot of legislation around access and use and ownership of cannabis even. So some women they really wanted to be able to grow their own, and they do grow their own, but there are limits to how much you can grow, and depends on how people live in the house and all of these different things. So they are really interested very much so in saying, we want to have control over access and use, and not feel like we actually have to go to a physician to prescribe it to us. So right now, and even before 2018, you could go to a physician and get a medicinal cannabis prescription. And actually, I have a colleague who is a geriatrician who worked with me on this in the early days of that project, who does prescribe medicinal cannabis to older adults. But they don't necessarily want it to be medicalized, their use, right? They don't want to, they're again, alternative to using prescription drugs, for example, they want to go a different route. So I think we have to think a little bit outside the box around where the knowledge is getting mobilized and who takes that up.
Thank you both. Ina.
Thank you, Alison and Saara. That was a wonderful presentation. One thing that struck me in, I think it was in Alison's presentation, the terminology of sexual dysfunction. If sexuality just changes after menopause for many different reasons, of course, lack of estrogens, maybe it's just the terminology will make women think that something is wrong with them and that they have to fix it. But there's so many different other approaches to it. I was just wondering, if that terminology should not be applied to specific changes in menopause, and it would be much more constructive to call it changes in sexuality rather than sexual dysfunction. Just a food for thought. It just popped in my head when I was seeing
So certainly, I think that those are just definitions from from looking at the sexual function, like there's the 4 phases of the sexual, arousal, orgasm, desire, and I forget what the 4th one, but anyway, there it's all based on the sexual model. And certainly I appreciate that. But then there's also, I discussed hypoactive sexual desire disorder, so HSDD. It's only a problem if you're bothered by it.
Yeah.
So there are many women who say, oh, I don't have a libido anymore. And I'm okay with that. It doesn't bother me. I'm more than happy just to read my book and other stuff. And, and certainly we don't need to call things a disorder if people are not bothered by them.
Yeah.
So certainly appreciate that. And then we want to be careful with labeling something a disorder unless it's causing distress or a problem.
Thank you.
Jules.
Thank you so much for your presentation, Saara and Alison. I feel like I learned a lot, and you definitely left me with a lot of questions. But I was specifically wondering how the approaches you took to your research lend themselves as like kind of countering a medicalized approach in a way, or for example, you spoke quite a bit about how the participants experience quite a bit of medicalized behavior and conversation when it comes to their symptoms around like menopause. And I was just kind of curious about how your methods impact or kind of go against those stigmas and like mentalities. I hope that makes sense.
Are you just asking both of us, Jules?
I think maybe for Jules.
Whoever
I'm
wants
sorry,
to
for
answer.
Saara. For Saara.
Yeah, sorry, you can answer too. And Alison, if you have anything to add, feel free.
Yeah, I mean, essentially, we're asking women to. I think I'm understanding your question as like, what is it about like the arts-based approach that sort of counters like a traditional way of getting information? Yeah. So yeah, so yeah. I just want to make sure that I was answering your question properly. Yeah, for these women, they were like, this is so great to actually not talk about this as if it's like when I'm talking about X, Y, or Z, that I'm actually talking about it in a language that makes sense to me, that I get to sort of, again, ask for what I need in my and really talk about it in my own terms. So like we had questions that we had asked initially, but we had said to the women themselves, like, are we asking the right questions? And they really helped us to define and think about what are the next questions to ask, because, they are really actually pushing against the medical / recreational dichotomy that exists in the language around cannabis consumption right now. That's really challenging for them because they don't necessarily want to ask for a prescription because they enjoy it as well. And they don't actually want their experience, whether it might be around their mental health or their physical well-being, to be seen as, a medical concern, that it's actually like they're engaging in like natural aging processes. And they don't necessarily want to feel like they have to explain that to a family doctor who may not really understand that there isn't that kind of distinction in their lives, right? So that will be important information to share to people that prescribe or not cannabis, and certainly it will be important for people working in the cannabis industry. And really, like, again, I this project wasn't intended to sort of be situated in the medical realm. It was more like in the socio-political and legal realm, because what the women are really talking about is there is a policy structure, like a health policy structure. There's a legal framework that is making it really challenging for these women to feel like they have a sense of control over how they take matters into their own hands, because that's what they choose to do. I don't know if that answered your question.
It did. Thank you so much.
Thanks, Saara. So, This one is in the chat from Deb Sloboda, one of our colleagues in health sciences. And she says, what do you think about bringing these discussions into clinical care much earlier than the onset of perimenopause, so that all women, regardless of age, understand how their health changes over their life course? Are there studies that think about this?
So certainly there is a study that is coming out soon through the Menopause Foundation of Canada. It's actually coming out sometime this week, because October or next week, menopause month is October, and they did a large study of women in the workforce who were experiencing menopausal symptoms, and it sounded about half of women didn't understand that the symptoms they were experiencing could be related to menopause. So there is a lack of understanding. We educate children about coming into puberty, and these are the things that you might expect to see, and this is the other end of the spectrum. There's not a lot of education or talk about this is what you might expect to experience, and 100% I agree with you. It's the other end of puberty, and we're not talking about it. Whether or not I see them when they've already had their symptoms. And so until people don't really see general gynecologists, I see them people when they're having a baby and then at menopause. So I tell all my patients who are pregnant, I'll see you again maybe in 20 years to help you with your menopause. But yeah, from family doctors and from primary care, there is a great opportunity for education, and having accessible information, perhaps in the waiting room, and to open the dialogue. But certainly having more accessible information and having that conversation would be super helpful for all women. And are there any studies? Just the one that I mentioned is that I know about, and just that I do know that there are some studies saying that women weren't aware that their symptoms were related to menopause.
Deb replies, say it's time to remove the stigma of ageism altogether, but especially in women. Thanks for the amazing presentations. Look out for the papers. I don't see any more questions here, and we're coming right up on 12:30. So maybe we will thank our speakers. Oh, I don't know, Alison, you might want to address this last one in the chat.
Okay, yeah, no, so this is absolutely not true. So it sounds like this person's family doctor was hasn't read the research since 2002. So that was the teaching in 2002. We've come 20 years later, and menopause hormone therapy is safe in the majority of women if started within 10 years of menopause. And so started within 10 years of menopause, but in the absence of contraindications, and there are way less contraindications for hormone therapy than there are versus the pill. You can have hormone therapy if you have high blood pressure, as long as it's controlled. You can have it if you have diabetes. You can have it if you've had migraines. You have it if you're a smoker. It is accessible and available for the majority of women, but the healthcare provider should be up to date on the research and not looking at the studies from 20 years ago.
Those are sage words to close out. So thank you very much to both of our speakers and to everybody who joined us today. This has been an excellent installment of the series, and really something that we would like to continue to think about and to support research in this area. So thank you very much, and we'll sign off for now and see you next time.